Hello, my name is Amir Fathi. I'm a physician and a specialist in leukemias and bone marrow cancers at Massachusetts General Hospital. I direct the leukemia program here, and I'm also the associate professor of medicine at Harvard Medical School. This year at the annual ASH meeting in Orlando, Florida, I was fortunate to be able to present the results of Paradigm, a phase 2 clinical trial that randomized younger, traditionally induction-eligible patients to azacitidine and venetoclax versus conventional induction chemotherapy. We enrolled 172 patients, 86 to each arm, to this study. The eligibility is important to note. These are patients 18 years and up with pathologically confirmed acute myeloid leukemia. They're functionally fit and supposed to be deemed by their treating physicians to be eligible for intensive chemotherapy. Of importance, certain exclusion criteria did apply. Patients with core binding factors, those with FLT3 mutations, and those with NPM1 mutations, if they were aged less than 60, were excluded from enrollment on study. We concluded enrollment and randomization in January of 2025, and we accrued across 9 U.S. sites. The study randomized in one-to-one fashion these patients to receive either intensive induction chemotherapy, either CPX or 7+3, in one arm according to convention, and in the other arm, azacitidine and venetoclax according to the prescription label with appropriate dose adjustment and monitoring over time. Patients who achieved response could come off of study treatment at any time and pursue stem cell transplant. Patients were otherwise followed for survival and important outcomes. Of note, there were important stratification measures according to age, as well as according to the choice of intensive chemotherapy, either 7 and 3 or CPX prior to randomization. After conclusion of the study, we began the analysis of the data in terms of safety and tolerability. The most common therapy emergent adverse events on the study across the two arms were predominantly hematologic, which is as to be expected and similar across the arms. However, patients who received azacitidine and venetoclax, a fewer proportion of them, significantly so, experienced infectious or bleeding complications reaching grade 3 or higher in terms of their intensity as an adverse event. Fewer patients on the azacitidine and venetoclax arm experienced mortality within the first 60 days. Almost 5% of patients had died by day 60 in the intensive arm versus 0 in the azacitidine and venetoclax arm. Similarly, azacitidine and venetoclax patients did not present to the intensive care unit during the first 30 days, as opposed to intensive chemotherapy patients, 10% of whom did. A larger proportion of patients receiving azacitidine and venetoclax achieved response on study. Overall response, composite remission, as well as the CR plus CRH rates were all higher for azacitidine and venetoclax, significantly so over intensive chemotherapy. Importantly, a higher proportion of patients who received azacitidine and venetoclax on study proceeded to stem cell transplant as opposed to intensive chemotherapy. The primary endpoint of this study was event-free survival, which was superior in the azacitidine and venetoclax arm versus intensive chemotherapy. This trend held even after a multivariable adjustment model was performed to correct for to account for age, risk classification, and various mutations. After this, the protective effect of azacitidine and venetoclax was still maintained. Overall survival was not different between the two arms, but we did note significant crossover following study-based treatment. For example, patients who received azacitidine and venetoclax on study, subsequently, if they had relapse or had progression of their disease, went on to receive induction chemotherapy, and vice versa. Those who received induction chemotherapy on study subsequently with progressive disease or persistent disease or relapse went on to receive a combination of HMA and venetoclax approximately 67% of the time. And with this degree of crossover, interpreting overall survival as an endpoint is quite challenging. We also assessed hospitalization metrics. Patients receiving azacitidine and venetoclax also spent less days in the hospital, both during the index initial hospitalization as well as during the initial 6 months following start of therapy. Patients who received azacitidine and venetoclax in comparison to those who received intensive therapy also had less visits to the ICU during the first 30 days of the hospitalization. Additionally, patient-reported outcomes suggested improved quality of life and depression scores for patients who received azacitidine and venetoclax. All in all, this data, considering the activity, safety, tolerability, quality of life, and other important risk healthcare utilization metrics, suggests that azacitidine and venetoclax is the appropriate choice of treatment for AML patients traditionally induction eligible, potentially transplant eligible, with intermediate or adverse risk FLT3 wild-type acute myeloid leukemia. Thank you so much for your attention.